one of our trainees, Dr. Carrier, put together our experience at MD Anderson, and that experience was looking at metastasis-directed therapy, or abbreviated MDT, for urothelial carcinoma. We're looking at both bladder and upper tract urothelial carcinomas. And this is something that hasn't been explored a lot. We know for prostate cancer, for kidney cancer, MDT has been, well published, and there's extensive literature, but for bladder and upper tract cancer, not as much. And so we looked at our own experience at MD Anderson. Around 52 patients or so is our final inclusion for analysis. And out of those patients, we were able to find a significant PFS and OS compared to some historical controls for systemic therapy alone when MDT with radiation was added for these patients. When they looked at the MDT being added to for patients with oligometastatic and oligoprogressive urothelial carcinoma, so these are patients with typically less than 5 sites of metastatic disease, and that could have included the primary site as well, that were either progressing or were de novo diagnosed. So they could have been oligometastatic or oligoprogressive. We looked at those patients having metastasis-directed therapy with radiation added in order to see if that would have improved their outcomes. And this was, interestingly enough, we saw that the progression-free survival was on the order of about 19 months. The overall survival was over 40 months. And so this is significant for patients with metastatic urothelial carcinoma, where we're having improvements in systemic therapy that are improving a lot of the OS and PFS endpoints. And I think of enfortumab vedotin EV as being one of the big systemic therapy advances. But we don't know how metastasis-directed therapy really plays into the kind of landscape of urothelial carcinoma with a lot of these newer agents like EV. And so I think this study, as compared to some of the other published literature out there on MDT for bladder and upper tract cancers, really highlights how the modern paradigm of treatment might look like when we're complementing systemic therapy with MDT with radiation. Yeah, so we looked at a few different factors to see who might truly benefit from MDT. Is there a difference between primary site for bladder versus upper tract? Is there a difference on maybe the dose of radiation, the number of sites? And so we did a regression analysis looking at those different factors. We were able to find a few things. Interesting enough, primary site, whether it was bladder or upper tract, we found there was no difference, that both patients probably benefited similarly with the addition of MDT, and there was no signal there. What was interesting, though, there was a few things that did stick out. One of them was that when we added MDT to all sites of disease, as opposed to being selective with our radiation treatment, we found a PFS correlation for improved PFS. And that is consistent with some of the data that we see in prostate cancer. So I think of the Oriole study, where total consolidation, as opposed to selective radiation treatments to metastatic sites, actually had improved PFS. And so we are mirroring some of that data within our own experience at MD Anderson. Great question. So when we're trying to add a therapy on top of systemic therapy, I think number one thing we want to keep in mind is that we're not, subjecting patients to additional toxicity, right? We're wanting to be basically an adjunct to systemic therapy, which is doing the bulk of the work. And so when we looked at toxicity, and this is consistent with a lot of MDT literature with radiation, we found very low rates of toxicity. In fact, I think they're among grade 3 plus toxicity, and out of those grade 3 plus toxicity, there was only 2 grade 3 events, no grade 4 events, and those grade 3 events were pain at the radiation site, which is usually relatively well tolerated and managed. So if you're looking at the safety profile for MDT, when we're talking about radiation, and many times this is SBRT, stereotactic radiation, it's a very safe profile, and that's consistent with a lot of other literature in prostate and in renal cell. Great question. So thankfully, we already have a study, and that's called the Extendo-P study. It's a basket trial. It includes patients with urothelial carcinoma and randomizes them to either next line systemic therapy. And just to be clear, this is oligoprogressive patients with urothelial carcinoma. So patients with 5 or fewer sites of progressive disease in the setting of metastatic disease. So we're saying if there's a benefit to adding MDT versus going to the next line of systemic therapy. So the randomization is a 1-to-1. Patients will get MDT, continue their same line of systemic therapy. That could be chemo, that could be EV, could be immunotherapy, or switch to the next line of systemic therapy, which is the current standard of care. And we're looking at progression-free survival as our primary endpoint of that study. And so that study has been open for about a year now, accruing very well, and hopefully we'll be able to answer this crucial question of, does MDT benefit patients with oligoprogressive urothelial carcinoma? Yeah, great question. It includes both bladder and upper tract. There's other baskets specifically for prostate and for renal cell. So it includes kind of all the GU primaries, but in different baskets within this phase 2 setting. So I think a really potentially high impact study that we have open at MD Anderson specifically in some of our partner sites.